This is the Fibromyalgia Educational Awareness offering that is vital for nurse practitioners to aid in the diagnosis and improve the quality of life of patients suffering from fibromyalgia. This program is designed to explore the assessment required in the diagnosis of fibromyalgia. The program also emphasizes an overview of possible pathophysiology, treatment modalities, and management. CEU's offered is 1 hour. The learning objectives for the educational program are demonstrate the complexity of fibromyalgia in patients, identify therapeutic pharmacological agents used in the management of fibromyalgia, and recognize non-pharmacological treatment for fibromyalgia pain management. To demonstrate the complexity of fibromyalgia in patients, specific objectives include describe fibromyalgia as a clinical condition and its social impact, differentiate fibromyalgia symptoms from other similar symptoms by applying the American College of Rheumatology diagnostic criteria, and identify possible pathophysiology related to fibromyalgia. The specific objective for identifying therapeutic pharmacological agents used in the management of fibromyalgia is to recognize the pharmacological choices in the management of fibromyalgia. The specific objective for recognizing non-pharmacological treatment for fibromyalgia pain management is to identify the role of proper nutrition, cognitive behavioral therapy, relaxation techniques, exercise in the management of fibromyalgia, and other non-pharmacological treatments. Upon successful completion of the course, the participants will be able to identify assessment criteria to use in the diagnosis of fibromyalgia and apply pharmacological and non-pharmacological treatment options in the management of fibromyalgia. Learning assessment for this course includes 1 case study and 14 questions total, 4 throughout the content and 10 at the end of the course. Let's begin with a case study. Maria, age 35, has complaints of pain located on each side of her body from head to toe. She states that she does not want to get out of bed in the morning. She states that she does not feel like eating and hurts so badly that she does not want to move. She feels that she is neglecting her family by staying in bed for hours. She states that her sleep is never restful and that she is tired all of the time. Her husband states that she cries most of the day or looks sad and dejected. He says that she is probably unable to continue to work because of the pain. She has missed 2 out of 5 days each week for the past year. Her regular physician does not seem to understand and suggests taking acetaminophen or Tylenol for the discomfort. Maria found another healthcare provider who referred her to a specialist, but that specialist stated that she needs further testing to find out the cause for her symptoms, which is going to take some time and money. Finally, a neighbor referred her to another healthcare provider who diagnosed her problem as fibromyalgia. She was grateful that she had a name to the myriad of problems. This whole process lasted 2 years until diagnosis. She and her husband were thankful that they had insurance. Stories like the one above are common for the patient with fibromyalgia. Unfortunately, a specific diagnostic test fails to exist for the diagnosis of fibromyalgia. According to Choi and colleagues, as discussed by Arnold in 2012, patients with fibromyalgia reported that it took an average of 2.3 years and assessment by an average of 3.7 physicians before the patient with fibromyalgia received a diagnosis. Nebraska Methodist College faculty conducted a study that was published in the Orthopedic Nursing Journal in 2016 to evaluate nurse practitioners' education and awareness of fibromyalgia and to evaluate nurse practitioners' practices for the management of fibromyalgia. The majority of the nurse practitioners who were surveyed, 95%, report that they were always or occasionally had difficulty diagnosing fibromyalgia. About 68% of the nurse practitioners surveyed were worried about labeling their patients as having fibromyalgia. Of the responders, 62% were aware of the American College of Rheumatology criteria to diagnose fibromyalgia. Of the responders, 76% reported spending time on self-education and 55% wanted more education. Women are 9 times more likely to develop fibromyalgia than men. According to a United States health insurance database, the mean number of physician office visits was 4-fold higher among fibromyalgia patients over 12 months that resulted in higher total health care costs. These patients were generally in poorer health and had greater levels of health care utilization than those in a comparison group. This disorder is seen in families with symptoms being displayed by children as well as adults. In general medical practice, it is estimated that over 5% of patients are affected with symptoms generally appearing between the ages of 20 and 55 years of age, with a tendency to increase with age. Sources vary, but there may be as many as 3 to 6 million American adults suffering with this condition. Baumstock and Bucklew, 2002, state that fibromyalgia is the 3rd most prevalent rheumatologic disorder in the United States. According to Arnold in 2012, fibromyalgia is a common chronic widespread pain disorder that has a worldwide prevalence between 0.55 and 5%. The history of fibromyalgia may shed some light on the lack of belief by some physicians. Back in the 1700s, physicians in Germany and Scandinavia were finding a condition with pain in muscles and soft tissue. In 1904, Sir William Growers named the disorder fibrositis, but in 1943, Slocum examined connective tissue nodules and found normal tissue without inflammation. Therefore, in 1981, Eunice et al. Coined the condition fibromyalgia, which indicates the presence of pain, but not necessarily inflammation. Some physicians may not recognize fibromyalgia as a real medical condition, since there is no definitive etiology or diagnosis based on a laboratory test. The diagnosis is based on patient history, physical examination, and the exclusion of symptoms of other conditions such as thyroid disease, rheumatoid arthritis, adrenal dysfunction, and psychiatric diagnosis. The majority of patients suffering with fibromyalgia have symptoms of chronic fatigue, widespread musculoskeletal pain, poor sleep, morning stiffness, and mood disorders such as anxiety or depression. Some may experience cognitive dysfunction, which is coined fibromyalgia fog. In the study by Hughes, of 107 fibromyalgia patients, the majority described their pain as aching, throbbing, sharp, tender, burning, gnawing, shooting, and pulling. The participants thought that the pain was exhausting, sickening, wretched, and caused them to be fearful. During the actigraph sleep portion of the study, the participants were recorded as having up to 26 awakenings during the course of one night's sleep. Diagnosing fibromyalgia is difficult because the symptoms can appear and disappear along with the degree and severity of pain. Many patients feel hopeless by feeling that these complaints will not disappear or are a psychological phenomenon. Fibromyalgia patients may look healthy and move around with no noted difficulty, but this lends itself to disbelief or the suspicion of malingering. The definition of fibromyalgia, according to the 1990 American College of Rheumatology, or ACR, is a medical condition based upon criteria which included at least 3 months of widespread pain. This pain occurs in all 4 quadrants of the body, with moderate pain sensitivity in the following tender points: occiput, low cervical, trapezius, supraspinatus, second rib, lateral epicondyle, gluteal, greater trochanter, and knee. The pain should occur on digital examination with 4 kilograms of pressure in at least 11 out of 18 specified tender point sites. This criteria was rather restrictive, however. The criteria stimulated further investigation. The 1990 ACR criteria created increasing clinical acceptance of fibromyalgia. Since this criteria was so restrictive, many healthcare providers decided that if a patient has typical symptoms of fibromyalgia but does not meet the ACR 1990 criteria, a diagnosis of possible fibromyalgia is often assigned. 1990 ACA criteria for fibromyalgia main points. 1. They have a history of widespread pain. Pain is considered widespread when all of the following are present: pain in the left side of the body, pain in the right side of the body, pain above the waist, and pain below the waist. In addition, axial skeletal pain, cervical spine or anterior chest or thoracic spine or low back, must be present. In this definition, shoulder and buttock pain is considered as pain for each involved side. Low back pain is considered lower segment pain. Pain in 11 of 18 tender point sites on digital palpation. That means pain on digital palpation must be present in at least 11 of these following 18 point sites. Occiput bilateral at the suboccipital muscle insertions, low cervical, bilateral, the anterior aspects of the intratransverse spaces at C5 through C7, trapezius, bilateral at the midpoint of the upper border, supraspinatus, bilateral at origins above the scapula spine near the medial border, second rib, bilateral at the second costochondral junctions, just lateral to the junctions on upper surfaces, lateral epicondyle, which is bilateral 2 centimeters distal to the epicondyles. Gluteal, bilateral in upper outer quadrants of buttocks in anterior fold of muscle. Greater trochanter, bilateral, posterior to the trochanteric prominence. And knee, bilateral at the medial fat pad proximal to the joint line. Pain in 11 of 18 tender point sites on digital palpation. Definition is pain on digital palpation must be present in at least 11 of the following 18 point sites. Occipital bilateral at the suboccipital muscle insertions, low cervical bilateral at the anterior aspects of intratransverse spaces at C5 through C7, trapezius bilateral at the midpoint of the upper border, supraspinatus bilateral at origins above the scapula spine near the medial border. Second rib, bilateral at the second costochondral junctions, just lateral to the junctions on upper surfaces. Lateral epicondyle, bilateral 2 centimeters to the distal to the epicondyles. Gluteal, bilateral in upper outer quadrants of buttocks in anterior fold of muscle. Greater trochanter, bilateral posterior to the trochanteric prominence. And knee, bilateral at the media fat pad proximal to the joint line. Digital palpation should be performed with an approximate force of 4 kilograms for a tender point to be considered positive. The subject must state that the palpation was painful. Tender is not to be considered painful. Over time, several practical and some philosophical objections occurred. The restrictiveness of the tender point count was not performed at the primary care provider's office, where most of the patients presented with a chief complaint of pain. The accuracy of the tender point assessment was not consistent. Philosophically, other important patient symptoms that interfered with the quality of life occurred, that included fatigue, cognitive symptoms, and the extent of other somatic symptoms. Further research was performed, which developed into the 2010 ACA diagnostic criteria. In 2010, the ACR changed the diagnostic criteria to include assessment of pain and symptoms over a period of a week, symptoms lasting over 3 months, and ruling out any other health problem that would present the same pain and symptomatology. A patient satisfies the diagnostic criteria for fibromyalgia if the following 3 conditions are met: widespread pain index greater than 7, and symptom severity SS scale score greater than 5, or WPI 3 through 6, and SS scale score greater than 9. 2. Symptoms have been present at a similar level for at least 3 months. And 3. The patient does not have a disorder that would otherwise explain the pain. For the widespread pain index, note the number of areas in which the patient has had pain over the last week. In how many areas has the patient had pain? Score will be between 0 and 19. Shoulder girdle left, shoulder girdle right. Upper arm left, upper arm right. Lower arm left, lower arm right. Hip, buttock, trochanter left, hip, buttock, trochanter right. Upper leg left, upper leg right. Lower leg left, lower leg right. Jaw left, jaw right. Chest, abdomen, upper back, lower back, and neck. The symptom severity scale score includes fatigue, waking unrefreshed, and cognitive symptoms. For each of the 3 symptoms in the symptom severity scale, indicate the level of severity over the past week using the following scale. 1, no symptoms. 2, few symptoms. 3, a moderate number of symptoms. And 4, a great deal of symptoms. The 2010 criteria will probably be utilized to a greater extent by healthcare practitioners, since Dr. Frederick Wolf noted that most primary care physicians do not use the tender point examination, but prefer to diagnose based on symptoms. Refer to the Fibromyalgia Network at www.fmnews.com, 1-800-853-2929 for more details about the 2010 criteria. In order for patients and the practitioner to embark upon a successful outcome, both must understand each other. Utilizing the 2010 criteria creates a working dialogue that assists with diagnosing and achieving an improved quality of life for the patient. Time to test your knowledge. Number 1. In 2010, the American College of Rheumatology, ACR, identified that the pain must occur on digital exam in 11 out of 18 body parts to be considered the pain of fibromyalgia. True or false? The answer is false. The tender point criteria was a part of the 1990 American College of Rheumatology diagnosis criteria. Okay, the second question for testing your knowledge. Symptom severity SS score consists of the severity of pain, decreased mobility, and cognitive symptoms. True or false? The correct answer is false. Incorrect symptoms are listed. It should list the following symptoms: severity of fatigue, unrefreshed sleep, and cognitive symptoms. Since the cause of fibromyalgia is not known, several theories have been proposed by researchers. Some research has demonstrated genetic predisposition with family members over several generations being diagnosed with the condition. First-degree relatives of patients with fibromyalgia are more likely to develop this disease compared to the general population. Traumatic events, infection, and psychological stress have been cited as possible precursors to fibromyalgia pain. 2 of the foremost researchers in the field of fibromyalgia, Clow and Crawford, suspect possible abnormalities in the hypothalamic pituitary adrenal axis, which can lead to faulty stress/adaptation responses with resultant change in the production of the neurohormones. The concept of sensory hypersensitivity or central sensitization has been studied in patients with fibromyalgia by researchers, resulting in increased muscle sensitivity by a normally non-painful stimulus called allodynia, and increased pain intensity triggered by normally painful stimuli causing hyperalgesia. Those suffering with fibromyalgia have demonstrated a deficiency in the production of cortisol, normally produced as a stress response. Serotonin levels have been commonly lower than normal, which may involve increased pain perception and stage 4 sleep disruption. Many fibromyalgia sufferers have an increased level of substance P and glutamate in the body, which usually accounts for an increased awareness of pain and nerve sensitivity, since they are key excitatory neurotransmitters and mediators of pain transmission through the ascending pathways. Increases in glutamate concentrations in specific brain regions, such as the insula and amygdala of fibromyalgia patients, have also been noted. In summary, the functional changes and pathological mechanisms behind the fibromyalgia chronic pain may include 1. Central nervous system CNS desensitization, 2. Dysfunction of the descending inhibitory pain pathways, 3. Peripheral nervous system sensitizations, 4. Release of inflammatory mediators. 5. Endocrine irregularity in the hypothalamic pituitary adrenal axis. And 6. Neurotransmitter abnormalities. Weierville cited evidence of demyelination of neurons and inflammation of peripheral nerve fibers in skin biopsies from the tender points of fibromyalgia patients, which could result from chronic stress and HPA axis dysfunction. According to Goldenberg, Burkhardt, and Crawford, found in the article by Martyr and Agris, possible steps in the diagnosis and treatment of fibromyalgia could be the following. Step 1. Obtain a history using the 2010 ACR criteria. Perform a physical examination. Consider such diagnostic tests as complete blood count, complete metabolic panel, thyroid stimulating hormone, and erythrocyte sedimentation rate. Step 2. Provide patient education about their condition. Assess and treat comorbid conditions that impact fibromyalgia, such as depression, anxiety, and sleep disorders. Administer the revised Fibromyalgia Impact Questionnaire, FIQR, to evaluate current status. And Step 3. Begin pharmacologic treatment trial with pregabalin or Lyrica, amitriptyline, also known as Elavil, or cyclobenzaprine, known as Flexeril. Begin non-pharmacologic treatment such as an aerobic exercise program, including pool-based work for deconditioned patients. Try a multidisciplinary approach with referral for cognitive behavioral therapy, and schedule follow-up appointments with the primary care provider every 4 to 6 weeks with reevaluation with the FIQR. Step 4. If minimal or no improvement, consider referral to a rheumatology, pain management, or other specialists as needed. Consider alternate pharmacologic treatment with selective serotonin reuptake inhibitors or use of combination serotonin and norepinephrine reuptake inhibitors, or use of tramadol with acetaminophen. Consider use of 2 or more pharmacologic options in combination. A commonly used tool in the evaluation of patients diagnosed with fibromyalgia is the revised Fibromyalgia Impact Questionnaire. The original instrument, the Fibromyalgia Impact Questionnaire, FIQ, was published in 1991 with some revisions in 1997 and 2002. Originally, the FIQ used a visual analog scale that required the practitioner to measure the patient response on a 100 millimeter line with a ruler. One question also required reverse scoring and the use of constants to convert the first 13 questions to a standardized scale of 0 to 10. Questions in the FIQ directed to a patient function assumed that the patient possessed a car, vacuum cleaner, and a washing machine. There were no questions directed to problems with cognition, tenderness, balance, and sensitivity to the environment, which are now considered important areas to assess. The FIQR was developed to ease the scoring, address the limitations stated previously, and promote more widespread clinical use. This instrument has 21 individual questions based on an 11-point numeric rating scale from 0 to 10, with 0 being the best and 10 being the worst. The tool is framed in the context of the past 7 days in the life of the fibromyalgia patient. The FIQR is divided into 3 sets of domains: function, with 9 questions ranging from brushing and combing hair to shopping for groceries; overall impact of fibromyalgia, with 2 questions related to accomplishment of weekly goals; and the impact of symptom severity and rating of symptoms experienced by the patient; level of pain, energy, stiffness, sleep, depression, memory problems, anxiety, tenderness to touch, balance, and sensitivity to loud noise, bright lights, odors, and cold. The scoring consists of a summed score for the function, 0 to 90 divided by 3, the summed score for overall impact, 0 to 20, and the sum scored for symptoms, 0 to 100 divided by 2. The total FIQR is the sum of the three modified domain scores. The maximal score of the FIQR is 100. In the psychometric testing of the FIQR, the total scores of the FIQR and FIQ were closely correlated. R equals 0.88, P is less than 0.01. The FIQR also demonstrated good correlation with comparable instrument domains in the SF-36. The tool had good discriminant ability between fibromyalgia patients and healthy controls, rheumatoid arthritis, systemic lupus erythematosus, and major depressive disorder patients. The FIQR is available in paper as well as electronic form. It takes the patient approximately 2 minutes to complete. The authors of the instrument have published a document with the interpretation of the FIQR results with the following scale related to the scoring: mild fibromyalgia 0 to 42, moderate fibromyalgia 43 to 59, severe fibromyalgia 60 to 74, and extreme fibromyalgia 75 to 100. The FIQR is available in paper as well as electronic form. It takes There is a user agreement that needs to be completed requesting the following information: licensee details of name, etc., context of use, project financing, language translations needed, and a listing of the details of the user agreement. There is no fee for use of this tool unless the licensee is involved with a for-profit organization. For further information on the use of the FIQR, the corresponding author is Robert M. Bennett at bennettrob1@comcast.net at the Fibromyalgia Research Unit, Oregon Hall and Science University, 3455 Southwest Veterans Road, Portland, Oregon 97239. Many providers use this scale to speak with the patient about fibromyalgia symptoms and help to set realistic expectations. The scale can serve as a great point of discussion and can be incorporated into each visit to assess if the symptoms improved even slightly or have worsened. It can make each patient visit into a more structured, objective session. The FIQR could even be sent home and the patient could do self-monitoring in conjunction with a journal of activities to help patients correlate symptoms to activities. It is usually recommended to use a combination of pharmacological and non-pharmacological approaches in the treatment of fibromyalgia. 11 European countries formed a task force to study interventions for fibromyalgia called the European League Against Rheumatism. In pharmacological management, tramadol, simple analgesics such as weak opioids, antidepressants such as amitriptyline, and tropicitran, pramipexole, and pregabalin were suggested by EULAR to reduce the pain of fibromyalgia. Pregabalin, at a dose of 450 milligrams per day, was found to be fairly successful in the treatment regimen. Hauser et al. Discovered through a meta-analysis that results were very positive for the use of the tricyclic antidepressant amitriptyline and the serotonin norepinephrine reuptake inhibitors, duloxetine and milnacipran, as first-line treatment for fibromyalgia. Other medications have been approved for the treatment of fibromyalgia, such as gabapentin, which works by blocking the overzealous pain response by the nerve cells. Some of the same pain medications may also promote sleep, such as cyclobenzaprine, amitriptyline, gabapentin, and pregabalin in the fibromyalgia patient. But pregabalin and gabapentin also cause dizziness, swelling, and weight gain. It is not recommended that zolpidem or benzodiazepine medications should be prescribed for fibromyalgia patients because of the additional drowsiness and fatigue. According to Carville, 2008, Corticosteroids and strong opioids are not recommended for fibromyalgia, not only because of their long-term side effects of constipation, nausea, and drowsiness, but the opioids may not be very effective since they bind to the mu, delta, or kappa receptor sites. The hypersensitivity of fibromyalgia from central sensitization does not respond well to the opioid action at the receptor sites. Opioids are effective for the relief of short-term pain, such as when patients with fibromyalgia have surgery. However, fibromyalgia usually constitutes long-term pain. The increase of deaths from opioid use has been steadily becoming a national crisis in America. Several laws are being created to address pain clinics, medical prescription usage, and educating the public. The increase in substance P and glutamate and lower serotonin levels may cause the nerves to exacerbate and prolong pain in a repetitive way so that the nerves are reactive to painful as well as normally non-painful stimuli. In addition, non-steroidal anti-inflammatory drugs, or NSAIDs, have not demonstrated to be effective in the relief of fibromyalgia pain. The ACR in 2010 has suggested that acetaminophen and NSAIDs may treat the discomfort from such comorbidities as rheumatoid arthritis, but these drugs treat the pain triggers, not the fibromyalgia pain itself. According to a 2006 survey of Fibromyalgia Network members, medications normally prescribed for fibromyalgia were ranked by the members according to benefit compared to side effects. The following medications were considered high benefit by the members: duloxetine to decrease pain, alprazolam, lorazepam, and clonazepam, which all help with sleep, pregabalin to improve pain relief and sleep, tizanidine and carisoprodol as skeletal muscle relaxants, modafinil used to improve daytime alertness, and tramadol hydrochloride, a pain reliever. All of these pharmacological agents have side effects, but the members thought that the benefits far outweighed living with the side effects. EULAR recommended the following non-pharmacologic approaches to the symptoms of fibromyalgia: heated pool therapy, exercise programs, cognitive behavioral therapy, relaxation, and psychological support. The Mayo Clinic suggests that fibromyalgia patients need to start with education about the syndrome, eat proper nutrition to manage weight, especially if inactive, and begin moderate exercise and stress-relieving techniques. The American College of Rheumatology suggests some self-care tips, such as making time to relax each day, setting a sleep routine, and exercise often, following the saying, "Start low, go slow," to avoid any pain flare-ups. Argoff in 2011 concluded that a combination of patient education, aerobic exercise, and cognitive behavioral therapy, which focuses on behavior change and positive thinking, was the most beneficial for fibromyalgia patients. The symptoms of fatigue, stiffness, anxiety, depression, pain, vitality, and social functioning improved in a multidisciplinary interventional study using warm aquatherapy, aerobic exercise, and psychological educational therapy, according to Carbonell Beza, Apicaricio, Chilon, Femia Delgado Fernandez, and Ruiz in 2011. A systematic review of fibromyalgia interventional research did conclude that aerobic exercise had positive effects on the global well-being, physical functioning, and possibly on pain and tender points in fibromyalgia patients. These same authors, Bush, Schachter, Overend, Pilesso, and Barber in 2008, noted that the research on the benefits of strength training is inconclusive. The American College of Rheumatology suggested gentle body-based therapies such as Tai Chi and yoga. Alternatives and complementary therapies that participants in the Hughes 2002 study used were massage therapy, heat therapy, chiropractic therapy, icing, electrical stimulator, biofeedback, acupuncture, acupressure, magnet therapy, and healing touch. Many of the non-pharmacological therapies are not covered by insurance companies, nor have been researched widely. Table 1 lists the pharmacological and non-pharmacological treatment recommended to patients with fibromyalgia. With the 2010 criteria, the diagnosis of fibromyalgia should be more consistent. Healthcare practitioners can follow the guidelines of EULAR and the American College of Rheumatology to individualize the symptom management for the fibromyalgia patient. Yet, more research is needed in the area of what prompts a pain flare-up, the amount of effective activity that an individual should engage in each day without an escalation of pain, interventions devoted to restorative sleep, and the role of physical trauma as an antecedent to fibromyalgia pain. The economic cost of fibromyalgia is high, with some patients having to give up positions or changing jobs to accommodate their symptoms of pain, fatigue, and morning stiffness. With the knowledge presented in this module, it is hoped that the healthcare professional can better understand the syndrome of fibromyalgia so that the patient need not suffer in silence. And thank you for listening.